Good afternoon, everybody.
Good afternoon, everybody.
Good morning to my West Coast comrades who are listening and joining us on the webinar today. This is the second webinar that BlackTree has hosted, and I have the pleasure today to be joined by my friend Chris Attaya from SHP. And today we're going to go inside the numbers and give you some updates on some of the data and understanding the impact that PDGM has had for us, and obviously the other update we have is regarding how COVID-19 has impacted us. So, believe it or not, it's been 6 months of 2020 already. So there's obviously a lot has changed in 6 months for this year. Even the presenters. I cut my hair, I shaved my hair off. Chris before yesterday had a ZZ Top beard. Was down to his belly button basically. I may have made that part up, but a lot's changed, for us, and then also in the industry. We know that PDGM was obviously the first impact that we had here early in the year, and then COVID-19 came in and threw us a curveball, and as a result, here we are today, 6 months later. So a lot of questions we've been getting has been around kind of numbers are you seeing with PDGM so far? What's been the impact of COVID on those numbers? What can you share any benchmarks or some of the early trends or some of the data that we're seeing? And that's exactly what we're here today to do. So we're able to share those numbers with you today. I know, like I said, a lot of people have been asking for it, and excited with the information that Chris and I are going to be able to share with you today. So here's the agenda. So we have a lot to cover. There's a lot of information that we want to share with you, a lot of very interesting updates and trends that we're able to share. So the first piece we want to share is really some of that early benchmarking data. What did the data look like for us in the first couple of months of PDGM? We know that some of that data was a little skewed early. There was a little bias early for the beginning months of PDGM. With some of the early institutional patients. So some of those case mix numbers might have looked a little higher in January and February, but we wanted to take a look at that. We obviously know that COVID came in, and right around that mid-March time period, depending on what region of the country you're in, you saw a big impact in terms of census going down. We know a lot of agencies, there was a pause on elective surgeries, which had a direct impact on therapy, which we'll get into. So we want to show some of the impacts there specific to COVID-19. We're then going to take a look at some of the PDGM trends, and that's where we're going to get into a lot of the details within each of the different components, whether it be the clinical groupings, the timing and source, the functional scores, the comorbidity scores. Really look at where we're seeing those percentages for the first 6 months of the year compared to what CMS had projected based on what came out in the final rule, and really the statistics that they use to develop case mixes and whatnot. We're going to take a deeper dive into case mix, and this might get a little technical for some of the audience, but it's actually some really interesting information and talking about some of the regression models and how they developed each of the components and how the different PDGM components impact your case mix scores are. So that's going to be a really interesting couple of slides there. One of the other areas we know has been significantly impacted nationally by COVID has been LUPAs. And we know that going into PDGM, that was going to be an area that was going to be significantly challenging as an industry in trying to manage those LUPAs and switching from that one threshold of 5 visits to now unique thresholds for each of the 432 HIPS codes. LUPA management has been a challenge. And then on top of that, COVID hit, and it's been an even bigger challenge. So we wanted to get into some of the details and some of the trends we're seeing there. The visit utilization trends, I think we're so used to in the old world looking at those average visits per episode, which were anywhere between 15 and 17 visits in the years leading up to PDGM. We want to get some updates on those numbers and see what the average visits per period is now. The other piece that we wanted to look at specific to visit utilization is a breakdown of therapy and non-therapy. We know that that was one of the other questions leading into PDGM is how is therapy going to be impacted? So we wanted to look at some of the early numbers there. One of the other agenda items we wanted to take a look at are the cash trends. That was one of the bigger concerns leading to PDGM, as we knew that there was going to be a cash flow crisis in the beginning parts of the year, just switching from that 60-day episodic reimbursement model to now the PDGM every 30-day model. So we wanted to share some of the trends there, and obviously we know that COVID had an impact within cash flow too. So we could take a look at some of the numbers there. And then really kind of a reflection piece is after we give all this information to you, we really want to have a leave behind of what should you be doing at your agency? How can you look at some of the data within your own organization and use it to make actionable decisions on a go-forward basis? So as we get into the data, the first piece I wanted to just point out from a housekeeping standpoint is if you look on the right-hand side of your screen, you'll see a bubble with a few different menu items. If you have questions throughout, go to that Q&A screen and feel free to populate your questions in there. Chris and I are going to try to save a few minutes here at the end to take some Q&A. In addition to that, we have live polls that are up right now. So if you go to the polls section, we have 3 poll questions. We're going to keep them up throughout the entire presentation. I think it's going to be a lot of interesting information that we hear in terms of the results from the polls. Similar to the last webinar that we did, we're going to have 1-pager to recap the webinar, and included in that is going to be those poll results. So I think there's some interesting information we're trying to glean from them. And then if you have, if you want to have a chat with any of the other registrants, there's a chat function as well. So definitely please contribute in terms of, like I said, answering those polls. And also if you have any questions throughout, please populate them in that Q&A section. So the actual data that we're going to look at, again, Chris and SHP were nice enough to collaborate with us here and share this data. In terms of the information that we're going to see, what is that based on? You'll see it's going to be based on just the PDGM period. So as we go through here, even though that there is that crossover for some of those PPS episodes into 2020, what we're looking at is strictly going to be based on PDGM periods. So that's going to be for all periods starting as of January 1st of this year, and it's going to be, the data will be as of June 9th. You can see there the date in terms of when that was that information was populated. We're going to be showing that comparison information like I told you before. So we're going to look at SHP's national database. So that's going to be showing those trends for big database that SHP has, and we're going to be comparing that to what came out in the final rule last year, which was a lot of the statistics built around those different PDGM components in terms of where Medicare thought the industry was going to stand in terms of the percentage of periods by each of those various PDGM components. So that's all going to be based on the 2018 claims data, which is going to be based on all claims that were paid and processed by that July 31st, 2019. So when we look at those percentages, you'll see information based on those claims. You can see there that third bullet. This is going to be the information based on either the later or the final claims data or the OASIS. So if there was no OASIS information, it's not going to be included. You need to have both of those pieces of information for it to populate the trend here. Another bullet here: questionable encounters are not included. I would say that's probably one area that the industry at large did a pretty darn good job in preparation for leading up to PDGM. Is understanding which of those primary diagnosis codes fit into that questionable encounter or not allowed category. I know some of the early data we looked at was we did see a small volume of QEs in the beginning of the year, but that volume is pretty much negligible at that point in some of my conversations I've had with Chris. The claims data is going to be January through April only. And you can see there, obviously we know that COVID-19 is impacting the data into the second quarter. All right, so we know that PDGM is new. So it's just some words of warning. So PDGM only applies to the 30-day payment periods, again, in calendar year 2020, which we mentioned. To kind of piggyback onto that, the total periods and the sequence of periods can also be impacted. I mentioned before you're going to have that early bias for some of the January and February information, where it's going to be more of those early institutional higher case mix. Also keep in mind, we're only 6 months into the year. So even when you look at, we don't have any data specifically in this presentation on length of stay, but if we were, keep in mind that you're not going to have those long length of stay patients necessarily counted in that information. This is still very new information. So the information is going to be valuable, but also take it with a grain of salt that it's still only 6 months, and we know that there's been a pandemic that's impacted that as well. A couple of other points here. January specifically, if you think about it, it's only going to have a very limited number of second period counts. So really, it's going to be only for those patients that started on January 1st will have a second period in January. So it would only be January 31st starts. So we know that those first periods have those higher case mix values compared to the later periods. So that's again going to be reflected in some of the statistics that we see with some of the data. We mentioned before, the source and timing is going to reflect that higher early institutional periods initially. And we're also going to see a higher proportion of first period HERGs coming from the hospital or an institution as a result. Again, understanding the reports and what parameters are used, he's going to go through that as he goes through some of the different data points here. And LUPA rates, again, another area that we're going to see some interesting trends, but keep in mind that those LUPAs might be reflected as a higher percentage as they're going to be probably sooner billed. They might be the earlier discharged patients who are going to be resulting in potentially a higher LUPA rate. So another piece of information to keep in mind as we go through the information. So with that, I'll turn it over to Chris, and he's going to start the impact of COVID on the volume.
Yeah, well, thanks, Nick. Glad to be with you today. And I think you talked about, what has been that impact on COVID, and we'll start right out with the slide that we're using to show year-over-year changes in starts of care within our database. So those are the lines that you see on there. The dotted line or the dashes at the top there is last year's data, and then that blue solid line across these numbers of weeks is the starts of care for this year. And what you can see is that it's really decreased from the beginning of March through the lowest point would be the week of April 6th, and then starting to come back up. That bar graph is that orange bar that you see is actually the percent change. And you can see that it got down as low as about 34% the week of April 6th. So clearly, COVID is going to have an impact. And so as we look at our numbers, as we kind of look at some of the trends, you got to remember that that's included in there, and that's going to have some impact as you look at your overall numbers. So let's get into some of the components. Nick, you mentioned this. We're going to be comparing the SHP database to what CMS had in their final rule. And when you look at the left-hand side here, it's interesting. You'll see that the top 4 clinical groupings is matching up closely, like the neuro, the wounds, the musculoskeletal rehab, as well as cardiac are each the highest percentage of periods that we see in the first 5 months of this year. What I'm also going to do on the right-hand side, and I'll do this on a couple of the graphics today, is share that period sequence. What did that look like? Do we see anything interesting in terms of some of the numbers? In the first only, what I'm talking about here is just single periods of which the patient was discharged or transferred and didn't come back. So first only versus any first would be any first periods that occur from start of care. And then the second plus is those second and third and fourth and as many periods as you might have expected for a patient for either starting this year or frankly even last year that then entered into PDGM sometime in 2020. I think the one thing that jumps out at me here, and I think I've got a little, I've got a way to kind of show you a little drawing here, is that 31% that you see for muscular skeletal rehab is pretty high. But that makes sense, right? Because we know that there are still those hips and knees that aren't that complex, that are in and out within those first 30 days. So that's one thing to see. And then when you look at wounds, or you look at cardiac and circulatory, you notice how they get a much higher percent in that second plus, and that's because they're staying on for a longer period of time. They're potentially going and being resorted. Those are the types of patients that we would expect to see there. And so, Nick, as we think about the trends.
So in terms of the trends, you'll see here, what sticks out the most, I think, is that if you look here, we'll go through January all the way through May. A couple pieces that stick out here are, again, I think what we probably expected is that during the COVID months, we would have seen a reduction in the neurostroke patients, which you can see for the neurostroke patients, it didn't happen as much. But if you look at MS rehab, that was really the clinical grouping that got affected the most. If you look here, my drawing skills are not as good as Chris's, so I'm just going to kind of highlight here. But yeah, you'll see here, for March, that MS rehab, or actually, if I go all the way back to January, MS rehab at that 21.6%, that started to slowly go down into March at 18.5%. And then in May at 15.5%, before it started to climb back up, or in April at 15.5%, and then it started to climb back up in May. So, that and the neurostroke, I was surprised that those numbers remained as steady as they would, just knowing that they're typically going to be your higher therapy patients. So despite the reduction for MS rehab, it is still, the second highest clinical grouping in terms of volume. The other two highest clinical groupings, which are wound and the cardiac patients, they continue to be in that top four, and you can see they saw an increase as well. So the wound care patients at around 13%, they start to climb every single month throughout 2020, going from January all the way through May. And then the cardiac patients, similar trends. They start out at 17.2% in January, and then you see those numbers increase throughout. Those are the biggest pieces I think we saw in terms of COVID impact specific to the clinical groupings.
And Nick, one of the things too, with the MMTA respiratory in April, we did see that also tick up a little bit because we started reporting on that for the first time with the availability of the new code. And when you look at the other components, this is kind of interesting. On the left-hand side, you'll see that for the comorbidity adjustment, look at that high category coming in at 14.1% versus what CMS had modeled out at about 8.1%. So some of that might be we're doing a better job at secondary diagnosis coding, we're paying more attention to that, we're seeing more codes on the claim versus maybe what was just put on the OASIS. It's the functional impairment though, Nick, I think that's the big change. Look at that high category at 43.8% versus what CMS was intending to do is to get, let's say, a third in each of those different levels. That's over 12% higher than what CMS had expected. And we'll talk a little bit more about that in some of the data. And then finally, with source and timing, you already hit on this a little bit, right? We're seeing a higher percent of early because we're still seeing a higher proportion of those, early periods occurring because we're still new with PDGM. And community late, we haven't quite caught up yet, but I think we'll see numbers continue to get closer to CMS as we go forward through the year when we have more opportunities for research that would continue to grow that community late period. In terms of period sequence, I guess the only one item I'd like to point out is this area here where you look at 17%, and I'm sorry, I kind of jumped over it a little here, but that 17% for high comorbidity shows up in those later periods. And if you think about it, those patients who were only on for the first period, they're maybe not as acute, they didn't need to continue on. Those that get into second plus, second, third, fourth, and whatnot, in terms of the period sequence, truly are more acute, and that's why we're seeing those higher levels.
And in terms of the trends, I think starting with the comorbidity adjustments, as you mentioned, Chris, I think that was one of the areas that we expected to show a difference in terms of the 2018 data to what we're actually seeing in 2020. We know that there's an added emphasis on coding for more complete and accurate coding, and as a result, we would expect some of these patients to fit more into these low or high comorbidity adjustment categories. And the numbers are reflected really throughout. If you look in January, that number being 12.7% for the high comorbidities, you can see it trends up all the way through April, hitting that high point of 15.1% in April. It does shift down a little bit in May, but for the most part, I think that's just a reflection of just more complete and accurate coding, which if you look at what CMS was anticipating with the behavior adjustment, that was one of those categories they were anticipating. And again, knowing that in the past, we really only had 6 diagnosis codes that went on that claim. Now we can have 20. You would have expected numbers here to be significantly different. To your point, I think the one area that surprised me the most is just the disparity in terms of the functional impairment scores, where Medicare had set that up. And if you look at a lot of the prior data from 2018 and even in 2017, the way they looked to set that up was that almost a third fit into those low, medium, and high functional impairment scores. And if you look at the actual data that's come out, there's a high percentage that are in that high category. So you can see it started off close to 42% in January, and then again continued to climb into the later months, and has gone down a bit in May, but it's still steady. If you look at that overall number, 44% of claims fitting into that high functionality category, and about a third fit into that medium category. But you can see where they're taken from in order to hit that high number at 44%. Is the low is only at 24%. So some interesting trends. Just looking specifically there. And again, I'm not sure what the trends from a COVID standpoint are telling us here. If anything, I think that again, it's more of us just getting used to what is really impacting the scores under PDGM. And again, as we progress through the year, I think you're starting to see just some improvement in the numbers overall. So the other piece here, as mentioned earlier, those early institutional numbers were definitely skewed in the earlier months, and you can see how dramatic that looks just in this chart here. If you look at the early numbers in January, early community was 22%. In February, it's 12.7. You can see it dramatically decreases each of those months. Community late, those numbers start to level out and become more normal. It starts off at 29.7%, and then all of a sudden we look at, here's the numbers that we were expecting when CMS released the data. We were expecting a lot more of those late community patients. It's probably skewed the other way come March and April, because we know that admissions overall were down significantly due to COVID in March and April. So now, instead of that skewing from the beginning of the year, where it was a high percentage of patients that were early institutional, because in those March and April time periods you didn't have as many admissions, it's mostly those patients that were coming up on second and third 30-day periods, and now all of a sudden the percentages are skewed the other way. So I think maybe by the end of the 6-month period we'll have almost normal numbers as those different impacts have kind of evened themselves out. But you can see again overall just the difference here. The community about 2/3 compared to community versus institutional, which again is where we thought we would end up. It's just our way to get there for the first 5 months of the year has been a roller coaster, just looking at the actual numbers themselves. And then if you look at the early late specifically, we're looking at an overall right around 60% late. But if you see here, obviously January really skews that data with 2/3 of the patients being early in January, and that number gets reverse skewed, so to speak. If you look at the April numbers, we're only 26% were early in April, and again, that's really going to be reflective of that impact on COVID. with the lack of or the significant reduction in census admissions.
That's a great point, Nick. So let me jump in. Let's do that little deeper dive you mentioned on case mix weight. And what I wanted to do is just remind you how CMS actually created the case mix weighting structure. They used the claims data from calendar 2018 to really look at what were the resources used or the cost consumed, using a regression analysis that kind of broke out the 432 HERGs to kind of come up with that case mix weight. And that cost of care was really based on a cost per minute, the actual time of the visit, plus added back in non-routine supplies to determine that resource use. And then, as you mentioned, Nick, they came up with a point thresholds for functional impairment to kind of get to this 1/3 for each of the levels, low, medium, and high. But then what they said is, we know about the behavioral adjustments, right? So they said that they were going to do that via a national rate adjustment. It was 4.36% that they decreased our rate, assuming that we would have behavioral adjustments. So just as a reminder, they had about $1,937 as a budget neutral value for what they were expecting for 2020. And so they reduced it down to the $1,864 based on that kind of half of the behavioral adjustment that they were expecting we would see this year. Because of that, they're assuming we're going to get back up to the 1,937. And the only way to get up to that is to have higher case mix adjustments. So if you take the ratio of those two, that's about 1.39, almost 1.039, almost 1.04. So you might expect that we should see, if we had hit the behavioral adjustments on average, a higher case mix weight other than 1. So just keep that in mind. I think that's an important thing to understand in looking at this data. So with CMS, this regression analysis kind of created these values that they would apply to each of the components, the early, late, in terms of timing, the admission source, the clinical groupings, the functional impairments, and we created a chart to kind of show you how case mix weights are then accumulated to get to your HERG values. And in this example, you can see in yellow, I've identified the case mix weight for the 3A2B, which is the HIPS code structure of that, but that is the MMTA other late community with low comorbidity and a medium functional impairment. So those are the yellow marks that you see that I drew. And it's interesting, CMS actually starts with a constant, a 1.0124, and then you add in the factors, both up and down, for community late, for the MMTA other, medium impairment, low comorbidity, and you end up with what you have is this final code, which is the case mix weight of 0.7901. So that's the case mix weight that you would see. So a couple points here. The impact of the late community is pretty significant, 0.4. And that's going to happen for any late community. So if you think about it, out of all of the HERGs that are late community, and we have many of them in the volume of periods that we would have, that's pretty sizable. The other thing I'd like to note is when you look at the high functional impairment add-ons, those are pretty significant. So you've got some pretty good values that are coming in associated with that. So what that brings me to is, looking at what the case mix weights are showing for the first 5 months. And I've excluded lupus in this example, but overall, the average for all periods is about 1.088. But as you would have expected, in period 1, where the resources are higher, these are the early, you're seeing a case mix weight on average of about 1.088. 3, 4, 5. And you can see that, the ones that we were expecting to be higher, like wounds and neurostroke rehab, are of the highest values. But then when you go to period 2, and then to period 3, and period 4 and 5, notice, they stay relatively the same. And just go back. Each of those are considered late. Most of those are community late. So you are seeing reasonable consistency in those codes because of that. And so I think the reflection here is, when you're thinking about budgeting, early and late, as you kind of categorize your periods, are one of the more important factors that you're going to want to consider in planning for your budgets.
And that's actually also very true here. If you look at the trend, if you look at the January numbers, we mentioned this before, that was obviously the highest percentage of early periods, and we see that reflected in the case mix scores. So we see that number of that 1.213. As we continue on to these later months, we see the case mix really start to normalize more, and it bottoms out, to no surprise, in April, which again is that month that we saw on the previous slides as the highest percentage of late periods, because of, again, that census decrease in the lack and the reduction of admissions. So, no surprise, I think, here. And again, you can see the direct correlation between, like Chris said, the timing and really what the impact in those numbers look like. Some interesting, if you look at, specifically within each of these clinical groupings, you'll see for the most part, from February to May, the numbers are pretty steady through each of these different clinical groupings. Maybe a percentage point here and there within the actual weights themselves. I would say the anomalies, or some of the exceptions there, would be the neurostroke numbers. You can see they bounce around a bit, with the from February right around that 1.2 number. It gets down to 1.15 in April, bounces back up in May. And some of the MMTA other numbers look like they've moved quite a bit, looking at MMTA specifically, and then some of these other MMTA different groupings, some of the numbers for them moved a good amount. But again, for the most part, the case mix numbers within each of the clinical groupings, if we just look at them separately, have remained pretty consistent since February through that May time period.
Yeah, thanks, Nick. And so as you kind of look at the case mix weight here, and that's the orange line that we're showing here, I wanted to overlay that against the percent of early periods, which are those blue bars. But in this example, I'm actually breaking it out by CMS region. So you can see CMS region across the bottom, and what the relationship was between the early periods as a percent to the case mix weight. And notice it's pretty correlated. When one goes up, they both go up. When it comes down, they both come down. And I think this is really reflecting on the fact that the early late against your case mix weight is the biggest reflection of how well you're going to do in terms of that case mix weight. The other point I just wanted to make is just, look at the overall total on that right-hand bar. It's 41%, right? That is considered early in our data set for the first 5 months. But boy, there's differences across the country. So CMS created a model that was based on all claims nationally. But depending on where you are and the types of patients you're seeing, I'm expecting we're going to see some real winners and losers depending on how that matches up. So I just wanted to make that point here, that it's a national model, but boy, it really depends on your specific patients. And in this example, depending on where your region is, you might see some broad differences in your overall case mix weight. So I had mentioned this quickly, functional impairment, we saw that is one of the, biggest increases, which is probably having a good influence to overall case mix weight. And I wanted to show the average impairment point. So this is just across the board by these different OASIS items that are used for functional impairment. And what I'm noting here is the overall total for the points was 51, just over 51. But in CMS's baseline, when they created the model, that was 45.9. And so that's an 11% increase that we're seeing, which is part of the driver, which is raising the number of the percentage of high functional impairment patients that we're seeing. I think a couple interesting things to note is, risk of hospitalization. It's a small piece. It's a small piece of the pie, but based on where CMS was expecting in terms of the model of their data, it was around 2.1. So that actually increased 50% between the base year model and what we're starting to see year to date. So clearly, agencies who might not have been as concerned with getting it right and making sure that they answer those questions as to the best of their ability, clearly are scrutinizing that much more closely. Grooming, actually all the other categories were also up, grooming in the same kind of way, but notice ambulation and bathing represent over 50% of the pie, 50% of where those points are coming from. So kind of interesting. I'm sure we'll be looking at that more closely in terms of what does that mean in terms of behavioral adjustments? Is this something that CMS was expecting? Is this something that CMS will change the threshold points to get back to the third as a part of the next time they reclassify, recalibrate the overall case mix weights themselves? Okay. Well, Nick, I'm going to take the first slide here and kind of do a deeper dive in the looper and visit utilization. And here I'm just showing the looper rates across the, different periods here, period 1 up through period 5+. And it's higher than what I think CMS was expecting. The overall average here is 9.5%, but in period 1, we can see the average here being about 9.9%. And as we were expecting, because we had seen this in some of our data points last year, it's period 2 where we see some of the highest rates being applied. Here it's a couple percentage points higher at 11.9%. If you look at complex nursing, the second from the top, that's high across the board. And we've known that that was going to be one that would have high looper rates. But look what happens in period 3. Those are the patients who are recertified, right? You've done an 04 assessment, and those patients are likely, more acute. That's why you're keeping them on a second period, and you're doing enough visits so that you don't really get impacted much by the looper percentage or looper cases. That drops down to 4.9%. Goes back up in period 4, and then you see that in period 5 it comes down slightly. So a couple things just to note here that I just want to point out, and that is, remember, when CMS created the model, they said that there would be looper thresholds for each of the 432 HERGs. And when you get to the late, which is period 2s, 3s, 4s, and 5+, they're all the same. So again, if you're doing more visits in period 3, yeah, that's why the rate's down. So you're likely to continue to see this because they're calculating the averages based on all 8s, which is the average of 2 through 5. So you'd likely see that when you start to average that out, it'll get closer to that 9%, probably where we are showing in period 1. One last point I want to make is, in period 1, it's kind of interesting, you could have a looper rate in period 1 and not have a looper rate in period 2. So just keep that in mind. We kind of looked at some of the data, and it said that if you had a period 1 only, patient was transferred because of hospitalization or got discharged early, actually the rate is much higher. It's about closer to 17, 18%. Whereas if they continue on, the looper rate for those that do have a looper in period 1 is closer to about 6%. So kind of interesting as you slice the data even further.
Yeah, thanks, Chris. And the other piece we obviously wanted to look at was some of the trend data, specifically nationally, and then what the COVID impact is. And we know that there are certain regions of the country that were more impacted by COVID than others, and different time points as well. One of our poll questions, which again, a reminder, please go to those polls and answer those questions, was how COVID impacted your lupus. And right now the poll results are showing that 22% of agencies have seen a 20+% increase in lupus due to COVID. So it's definitely, again, regionally, certain pockets of the country definitely got impacted more than others, and that data is reflected right here. So we wanted to show the national trends for the data. If you look at from a national standpoint, the lowest month being January, we really started to see those numbers start to spike up right when COVID hit in March, up to 11.9%, and went back down in April at 8.7%. So you can see that overall number for the first 4 months of the year is right around 9.5%. Now, again, let's look at some of the specific regions of the country, and I'll start with Washington State. We know that was probably the first region in our country that was most majorly impacted by COVID. And I know we have some folks from Evergreen Home Health who are listening in. They were really at the epicenter of when COVID first hit. You can see their numbers specifically. They really started to go up in February when we first started to see those first cases. They spiked up to 12.3%. And then if you look at the March numbers, that's really when the numbers dramatically increased. They went up by 60% compared to January numbers of up to 16.2%. Luckily, it looks like they've rebounded here in April down to 10.8%, but that's definitely one of the areas that was first and also most majorly impacted by COVID. Look at some of the other hotbed areas, especially early Massachusetts and New York specifically. You can see similar trends where they did see an increase in February. And to Chris's point, I think we would have expected to see that regardless of COVID. But when you look at the March impact, really those numbers started to increase. Again, New York is up over 60%. Same with Massachusetts, up over 60% compared to their January numbers. Close to 14.2% for Massachusetts and 15.5% for New York in March. Again, the good news being those numbers have come down in April. I think we've gotten a little bit more efficient with just how we're caring for patients and making sure we've adapted as an industry to this quote unquote new normal. And I think the numbers specifically for lupus are reflected in that. We wanted to throw Texas in there as well because that's a state that hasn't been as impacted, at least for the first couple months of COVID. And you can see for Texas specifically, they had a low lupus percentage to begin with. So if you look at the month of January, they were 5.5% compared to the national average of 7.8%. Their numbers did start to spike up. So even I would say a state that hasn't been as impacted. At least again in those early months. Now we are starting to see the numbers rise there and certain pockets of the country like Arizona, Florida, and the Carolinas. So it'll be interesting to see what these numbers look like here in a couple more months from now. But even Texas, you can see the numbers started to increase in March and again go back down in April. So some interesting data here to look at again for the first 4 months, but it'll be even more interesting to see, especially for these states that have rebounded from COVID and the cases started to decline. If we start to continue to see that trend of those lupus numbers going down as well. So something again to definitely keep an eye on.
Great. In our last kind of deeper dive into the lupus rates, I just wanted to show you this. It's kind of a busy slide here, but we're breaking down the lupus rates by visit threshold. As you know, of the 432 HERGs, they each have a threshold assigned to them based on the 10th percentile of the visits that CMS had calculated, or 2, whichever is greater. And the visit thresholds, are 2, 3, 4, 5, and 6. And not all clinical groups have all thresholds. In fact, if you look at that last column, you can see it's just neuro, stroke rehab, and musculoskeletal that actually have herd values that could even could even have a looper rate at the 6th level. So the thing I wanted to point out here is, complex nursing. We know that that's the problem one, but it's the highest in the looper rates for when they have a threshold of 2. And, as you look across, it's kind of interesting. Look at that overall rate here. If we start at the 8.9% overall average, and then you work your way to 3 to 4 to 5 to 6. Notice how as you get up to 5 and 6, that those are higher rates. And, so that kind of makes sense in some respects. 5 is the higher threshold, 6 is the higher threshold that you have to meet in order to be able to not have a LUPA impact. But you have to ask yourself, how many of my patients do I need to kind of think about in terms of managing that have those higher thresholds? And so at the bottom here, I just wanted to point out, what percent of HIPS codes are represented by each of those. And you can see that the HIPS codes, there's 21.8% of all of the HIPS codes that have a 2 threshold, but within our database, they represented 36% of all the periods that had a LUPA. And so that kind of tells you, where would I emphasize or kind of track and manage my patients such that I get the best value in terms of, scrutinizing the data. So I think that's kind of important to understand, thinking about where your problem areas might be, and then creating the kind of workflows that allow you to address those as a part of managing your overall LUPA rates. So that was LUPA. So we're gonna spend a little bit of time now, a deeper dive on some of the visit utilization, and this is based on standard payment. And what I mean by standard payment, it's not LUPAs, it's not PEPs, it's not outliers. So I've kind of excluded that from this the averages that we're looking at here, and this is just across all periods. So this is by discipline, and what you would expect to see is those clinical groupings that have the higher case mix weight typically have that higher visits, because it's the visit costs as well as the non-routine supplies that were driving the case mix weight. So neuro, stroke, rehab, wounds, and musculoskeletal, those are all over 9 visits on average. Now, you also see that wounds, much higher relationship of nursing to total visits, as well as you would think that for PT and OT, a much higher level of visits for musculoskeletal, as well as neurostroke, as it relates to the overall visits. So that's a little bit of what you see there. And then Nick, what do you see on the trend?
Well, it's interesting on the trends. I think you and I talked about leading up to this is what are we seeing for trends from a rehab standpoint? We know that was one of the big questions leading into PDGM, as I mentioned before, is how are agencies going to adjust in terms of therapy utilization? But I think the bigger question came about when COVID hit is what is going to be the impact on therapy? I know a lot of agencies were scrambling with the lack of therapy visits and the lack of, again, elective surgeries going on throughout the country. It really put a strain on therapy volume. So, and that's reflected in these numbers. As you can see here, the January numbers of 5.3 visits per period, that dwindled all the way down to 3.69 in March and 3.64 in April. So an over 30% reduction there. The other disciplines, the nursing, social workers, and home health aides, they did see a decline as well, but it wasn't nearly as significant as it was for rehab. So going from around 5 visits per period down to 4.6, 4.8, only a reduction of 8% and 4%, not nearly the impact that we had compared to the rehab. Now, the one caveat I'll throw in there is, again, keep in mind if we're just comparing to January, we would expect those January numbers to be higher because there were going to be a higher percentage of those early institutional, which again, if we remember the data, the early institutional patients have a higher case mix because they have a higher utilization. So even if, let's say, we averaged out January and February, you're looking at about 9.5 visits per period, compared to if we average out March and April, it's around, closer to 8.25, closer to 8.5. So it's still down, a visit and a quarter almost, if you're comparing the March and April average utilization to January, February. So again, something I think it'll be interesting to see, specifically May and June, and as we go beyond, I would expect these numbers to pick back up. And I think we all expected these numbers to be down in March and April, especially when you consider telehealth or virtual visits aren't going to be included in these counts. When that data starts to become billable, hopefully, fingers crossed that happens at some point in time, that will definitely show different numbers than what's reflected in the data that we saw here for the first 4 months.
Great. Yeah, thanks, Nick. And just another breakout that we wanted to share with you today is, by payment type. I haven't seen that much data yet out on that, but overall, we know that the average visits was at 8.9, and you can see the distribution there by clinical group. And then the standard, which is again non-LUPA, non-PEP, non-outlier, versus those adjusted periods. The average LUPA rate was about 9.5% of the periods, and averaging just under 2 visits, with PEPs really small. I was really surprised. We haven't just seen that many PEPs at this point in our data set, just 0.1%, but boy, outliers, at 5% of all periods, and the size of the number of visits per period are pretty high at 24. So helpful to kind of start thinking about that in terms of what that might mean for your data and how you think about the kinds of patients you're receiving. So in this next graphic, I just wanted to share, because looking at average visits per overall grouping is one thing, but when you break it out by period, this is where we see some of that difference between that case mix weight that we saw earlier, where we have a much higher number of resources or costs consumed in period 1, averaging about 11.1 visits within that period, where they then jump down as a part of period 2, as you start tapering those visits, and then jumping back up with period 3, where we have those more acute patients who are being recertified, that would continue on, that kind of increases the visits in that period, and then coming down again in 4, and then I guess technically it goes up in 5 and down in 6 is a kind of relationship between the kind of tapering that we're seeing towards the end of a 60-day clinical episode that we've seen in our data in the past. I just want to make one point though. In period 2, there are patients who are only going to be on for 60 days, right? They're going to have visits in period 1, and then, you'll be starting to wean those patients, taper the visits down in period 2. When they end in period 2, so they're only on for 60 days, the actual average in period 2 actually jumps down to about 5.5 visits, because you've tapered them down. I'm not including those patients who are more acute that are going to go into period 3. So just keep that in mind. As you look at the data, there's a lot of different ways to slice it and think about it. And I think that's going to be important as you start to reconcile your patients and how to think about forecasting and then, budgeting for next year.
Absolutely. Thanks for sharing that. And it's actually reflective, but one of the questions we ask is for PDGM, which operational change have you made that is making the most impact at your agency? And 85% of the responses has been really around, I would say, visit utilization. It's either developed a different utilization review process, increased the use of case conferencing for setting a plan of care, or establishing visit protocols and guidance. So I think that's all very much reflective of some of the visit utilization stats that we're seeing. Again, a definite added emphasis here under PDGM. So now that we went through a lot of the different PDGM stats and specific benchmarks, one of the other areas that we wanted to focus in on here is just cash flow and some of the cash trends in terms of what we've seen versus what we projected. So this chart here will show you some of those cash flow impacts of PDGM so far. So if you've seen any presentations that Chris and I did, or some of the other presentations that we did towards the end of last year leading up to PDGM, one of the big questions was, what is going to be the impact of cash flow? And we know that there was going to be a negative cash flow impact of the year, just in the nature of switching from that 60-day episodic reimbursement with those higher HERGs to the 30-day PDGM reimbursement. And then on top of that, we switch from a 50 or 60% wrap reimbursement, of the percentage of the HERG value, down to that 20%, which we're experiencing now in PDGM. So we knew that there was going to be a cash flow dip here in the early parts of the year. So if you look at that blue line, that reflects what we projected, and there's a number of different variables which are going to tell you how much money, how much cash is going to be impacted and at what point in time. We looked at, days to wrap, days to final claim. We looked at your revenue impact, your periods per patient. All those factors played a role in terms of what you're seeing from a cash flow impact. So using some of those benchmarks for industry best practices for days to wrap, days to final, we were estimating around a 22% reduction in January comparing this to December cash. In February, that dipped down to about 37% projected. Again, this is all comparing back to December. And then we're expecting a nice spike in March, an increase of about 12%, and then it starts to normalize in April and beyond. What actually happened was, January, February, pretty close to what we expected. This is for BlackTree specific clients that we're completing billing and collections functions for. But again, you'll see it was an initial cut in January, a deeper cut in February. But what the impact of COVID was in March, we never saw that spike back above those January numbers. So we got it back to right around even numbers to December, and then it started to climb back down in April. Down about 7%. So again, something to keep an eye on. And I know one of the other questions we asked in the poll was, what are currently your biggest operations concerns? 22% of you said cash flow. So, and I know there's been a lot of relief funding come through for COVID between the CARES Act, the PPP dollars, and some of the advanced payment money. But cash flow is definitely something you still want to keep an eye on. And as you're assessing agency performance, something that you definitely want to keep first and foremost in your mind. All right, we got a couple minutes left here. One of the pieces I wanted to discuss is, now we've seen a lot of this data. It's great information. Very happy to have Chris share the information from SHP. So what do you do with this? What can you do at your agency to evaluate your performance under PDGM? I think first and foremost, you want to take a look at the benchmarks we presented here and measure yourself. How does your agency compare to some of the numbers that we saw in this presentation? And it's important to remember, you don't want to just look at high level, okay, I know my revenue is doing this or my case mix is here. You want to make sure you're really taking a deeper dive into what's impacting that case mix. Is it different functional scores than what you're expecting? Are you getting higher comorbidity adjustments based on your coding? Is your clinical grouping distribution a lot different than what you anticipated? Those are all factors which are going to play into what that case mix is. Same with LUPA percentage. Is it something that your LUPAs are significantly higher than what you expected? Obviously, trending the data right now is a little difficult given the skewed numbers in the beginning and the skewed numbers during COVID, but it is still looking at those overall numbers, comparing to budget, comparing to the benchmarks that we outlined here, still a very valuable process to go through. And then, looking at cash flow specifically, as we know that's another area that agencies really need to be paying attention to now. You really want to assess those billing key performance indicators, looking at your percentage of collections, looking at your unbilled, looking at the different AR levels, and obviously also keeping an eye on that cash flow going forward. So just a couple charts here that are some good numbers to look at, and again, trend over time for the first 6 months here of 2020. So with that, we're couple minutes here before the hour. I'll open it up to some Q&A. I know I did see a question of, are there going to be handouts available? Actually, one of those menu items, if you look, you have the Q&A menu item, the polls, there's the handouts, and that's actually going to be where you can find a copy of the presentation. One question I did have, and Chris, I know you had a slide on this, but I don't know if there was any generalities you wanted to speak to. Any regions of the country where you're seeing a higher case mix compared to others? I think you're on mute here, Chris. Let me just unmute yourself. There you go.
Yeah, thanks. I was trying to be quiet for a couple of your slides there, but yeah, in one of the slides, I think we did share what the case mix weights looked like by region, and so it was actually the Northeast region that had the highest case mix weight associated with the data in our national data set. And so the question is, why is that? There's probably a lot to think about, what percent of those are coming out of institutions that are leading to, those higher rates that are early, that may get in and get out faster. So proportionally, a much higher percent of early. So I'm sure that has something to do with it.
Great. One other question we just got here is, do you have any data related to, do we have any data related to number of periods per episode, or maybe periods per patient? I know that's one indicator that we're suggesting agencies take a look at. I know it's pretty early.
Yeah.
Any insight there?
Yeah, we do share that on one of our scorecards, our PDGM detail reporting. And I don't remember the number offhand, but yeah, it is still a little bit early because, we don't have as many patients who have been on those longer periods just because it's still early. And so, my guess is it's tracking somewhere around 1.7, if I recall, but my guess is it will continue to increase as we get those patients who stay on for multiple recertifications and then add to that overall number.
Yeah, and actually that's a conversation. This is length of stay, same thing, where we said length of stay, but when we looked at the data, just the numbers look so low because we haven't really been in PDGM long enough. So that's a good question, though. Another question for you: do you know what percentage of patients are discharged in the first 30 days versus go on to multiple periods? Any insight on that?
Yeah. I ran some numbers the other day, Nick, and I'm actually on my computer here where I can't open it up real quick, but I can kind of respond to if that was Tony that sent that in. I can give him some insight there. What's been interesting is that number seems to have come down somewhat over the first 5 months that we've tracked it. Because, I think CMS was predicting it was going to be about 22%. And this is probably an area that might be a behavioral adjustment, right? The numbers of cases that would be first period only. I remember seeing something that suggested it was getting down to as low as 10%. Again, but don't quote me. And maybe what I'll do is I'll respond directly to Anthony or Tony about that.
Great. One other question I'll take from asking if we have any insight into when RCD might begin again. That's a very good question. The guidance that they've given is that the unpause button isn't going to be clicked until the pandemic is over. But so no new information there. Obviously, for the states that have already begun with RCD, it's paused, but you still want to make sure you're submitting those requests, because once on pause does get hit, that you're going to have to resubmit those records and essentially have each of those claims be somewhat ADR'd. So, but no new update in terms of when RCD might begin. Same with the new OASIS. The new OASIS was set to release on January 1st of next year. That's been infinitely paused for indefinitely rather paused until the pandemic ends as well. So continue to look for updates regarding that. One last question I'll give to you here, Chris. Any additional data on profitability trends with the different clinical groupings with the new visit data?
Yeah, we do share that. We do a national standardized margin in our reporting, and to be honest with you, it's looked actually pretty favorable. I believe if you think of a national rate, but using your inputs of time or visits within your 30-day periods and non-routine supplies, it's been averaging around 26, 27%. And so, yes, there are differences by clinical grouping that, again, it's also going to be dependent on the kind of plan of cares that you designed for your patients. But again, a little more favorable than I had originally thought, thinking that CMS was expecting it to be in that kind of 14% area if we had the behavioral adjustments that they were predicting.
Great. Well, we're a couple minutes past here, but I appreciate everybody listening and joining us today. We had a record number of people who tuned into the webinar today, so appreciate everybody listening. And Chris, really appreciate you joining me here and sharing the data, and hope you thought it was as valuable as we did, and obviously some of the listeners, because we had a lot of them that stayed on the whole time as well. So appreciate everybody, and thanks again, Chris.
Yep, glad to be with you, Nick. Take care.
Take care.